So today we're going to be talking about a project that has been focused on mapping neighborhood vulnerability to COVID-19 here in British Columbia. If you're based in British Columbia, you may have heard or seen about this project on the news, in the newspaper, or through other meetings that you've been a part of. We know there's been quite a lot of uptake of the work that we've done. And so again, we're very happy to be here to present this. I want to acknowledge as well, and you can see this on the slide, that in addition to Leah and I, there's a number of other members of our team, including Dr. Nadine Sherman, who's a colleague of mine at SFU, Dr. Melissa Giesbrecht, who's the research coordinator, master's student Jessica Tate, and then also we were very, very fortunate to be able to work with two patient partners on this project who were able to provide their input to all facets of the study, and their involvement was supported by the BC Support Unit. So there's nothing earth-shattering on this slide. You're going to see the kind of tweets that I saw in early January of 2020, where we were sort of first seeing the emergence of something that looked like it was maybe going to draw some of our attention. I put these tweets here because I wanted to share that at the outset of the pandemic, I think my first response was really as a person, just kind of thinking, what's going to happen? What are we going to see? And as that moved forward, I started to think as a health researcher, well, what can I do to contribute to the conversation? What can I do to help to support the ongoing dialogue? Where can we take this? And what can my skills as a health geographer perhaps contribute to the conversation? And as those initial thoughts merged with my thinking as a health geographer, I sort of came to the conclusion, and actually here you're seeing a slide where on one side you're seeing a co-edited book that I produced that's already out and available, that's offering what we're referring to as a pandemic geography's perspective on the current COVID-19 pandemic. But as we reflected in this, the outset of this book, as health geographers, I think many of us started to realize that as social scientists, there was space for us to contribute to the dialogue in terms of what's going on with regard to the pandemic. And then as I started to think about the fact that, potentially my skills as a health geographer could come forward to offer some support or unique perspectives, I saw this call for funding from what was formerly at the time the Michael Smith Foundation for Health Research, and had a real, I don't often quote Oprah Winfrey in a presentation, but it was true. I did have a genuine sort of aha type of moment, because in their call for proposals where they wanted to explore different kinds of emerging opportunities with regard to COVID-19 in a rapid funding context, one of the things they asked for was for researchers to consider what I've put at the top of this slide. So human geographic considerations in BC, including rurality, community, culture, population movement, with a view to preventing transmission and mitigating effects. I have to say that as a health geographer, it is incredibly rare to see a call coming out of a health research funder that is specifically asking for consideration of human geographic factors. So this was that aha moment saying, okay, you know what, this funding call has emerged, and I think that I can draw on some of my background work to actually bring forth a new perspective. So specifically what I'm referring to here is work that I'd been taking part in over the last decade in collaboration with Dr. Nadine Sherman, that has merged together qualitative NGIS perspectives in thinking about health service siting. So the work that we had done actually focused on palliative care. We had built a vulnerability model to think about where palliative care infrastructure should be strengthened within British Columbia, undertook qualitative research to support the kinds of variables that we were incorporating into that model, and then ultimately ran the analyses. So you can see little snippets of that type of work, or those papers at the top of the screen here. So I felt like we could potentially build on this model where we were creating vulnerability or suitability models and actually extend it into thinking about vulnerability in relation to the COVID-19 pandemic and British Columbia's neighborhoods. And so that's exactly what we've done in this project, where we set out as our goal, as you can see here, to produce a series of maps that will identify specific locations in BC that are at risk of experiencing high rates of COVID-19 infection, of inadequate spatiotemporal access to ICU care, as well as being vulnerable to the secondary effects that the pandemic can be produced that can be used to support informed decision-making. And so in this presentation, we're going to focus on our development of the first of these three models, the one that is focused on specific locations in BC at risk of experiencing high rates of COVID-19 infection. And then also later on, I'll just share with you some of the insights around our model that has focused on the secondary effects that the pandemic has or may produce. So the objectives of this work that was funded by the Michael Smith Foundation for Health Research in one of their rapid calls for COVID-19 research were threefold. We wanted to create and run a new set of vulnerability models. So we actually called them the Corvix models. That's our sort of inside or team speak for the work that we were undertaking that can facilitate public health and health services decision-making around COVID-19. So effectively, where our models can be used as a decision support tool. We wanted to refine our models as new information became available. So for example, I'm sure many of us can appreciate that factors that we thought were important as a team at the very outset of the pandemic, some of them are no longer even part of the public dialogue. At the point at which I was writing this proposal for Michael Smith Foundation, COVID was very strongly focused in Italy. There was a lot of discussion around age. There was a lot of discussion around smoking. There had yet to really be outbreaks in Canada to any great extent. So you have to imagine that those types of contextual or environmental factors were really anchoring our thinking from the outset. So we wanted to make sure that the work that we did would be responsive to new information as it became available. And then finally, we also wanted to incorporate a qualitative component. So we wanted to, as I've said here, actually dialogue with end users to be able to obtain feedback on how our models can be improved and also to assist with interpreting the results. So how would the work that we're doing actually be useful in your decision-making context? That was really important for us from the outset of the work. We wanted to be able to capture some of those insights. So I'm going to now focus on our first model. This is going to be the bulk of the presentation. And also in a few moments, I'm going to pass it over to Leah, who's going to share some of the specific work that we did to create this model. So the process that we used to develop this model was first we looked to identify variables that we felt contributed to risk. So what is it that contributes to the risk of contracting COVID-19 when you think about different neighborhoods in British Columbia? That was sort of the question that we were asking from the outset. The second thing that we needed to do was identify what kind of data were available that would help us to actually incorporate that variable into the model. So if something was coming up in popular discussion or in the scientific literature as being important, but there's no data that we could actually link to it, then that's not a variable that we could actually incorporate into the model. Then our next step was to actually integrate that variable into the model with the data that we have to support it. So we were able to use kind of two types of data, either census data or location data. So actually pulling addresses, which we did for a few of the variables. Our next step was to seek feedback on the model or on the maps from key informants. So that was gathering that end user perspective that I mentioned that we wanted to capture from the outset. And then following getting that end user feedback, we wanted to refine the models and then also create the maps in a format that we could share widely. So we have created them in the story map format as interactive maps that people are able to look at. Unfortunately, I can't see the chat screen, but if it's not in there yet, it will be a link so that you can follow along and actually look at the model yourself or the maps. So I just wanted to kind of acknowledge that I think with a lot of projects that are exploratory, again, this was a rapid funding opportunity. I believe the proposal was 2 pages in length with no references. It was a very quick assessment. And then we got the green light to go ahead and we thought, okay, what are all the things that people are talking about that actually matter in relation to contracting COVID, developing COVID, and that might be relevant at the neighborhood level. And we were gathering all kinds of variables. You can even see in the middle of this list, wildfire smoke was part of the discussion. You have all kinds of factors that were discussed as being important. And I think that at the outset, we weren't even sure how we were going to sort of organize them or really think about incorporating them into our model. And then we sort of had this critical moment where we actually realized that we were capturing two very distinct types of variables that we wanted to incorporate into our model. So I'm going to invite Leah to come up to share with you what we realized that we were actually capturing and to talk through some of the sort of more technical aspects of the project. And then I'm going to come back and comment on the qualitative component.
Thanks so much, Valorie. So I don't want to get into the weeds too much with these models, but I do want to give you all a glimpse into the conceptualization and process of their development. So the light bulb moment that Valorie just mentioned led us to define vulnerability according to the following equation. So vulnerability equals a person's relative infection risk and the relative exposure risk combined. And using this equation or concept of vulnerability, we then developed two separate indices to model the personal and place-based variables that contribute to transmission and exposure risk, respectively. Next slide. The first model we developed was a relative infection risk index, and it consisted of 7 indicators. So as you can see, these were whittled down considerably from the list Valorie just showed. And the 7 indicators include things like living in a large household, living in a crowded household, not knowing English, working outside the home, being employed in a high-risk industry, being a public transit user, and being socioeconomically disadvantaged. Next slide. So to construct the relative infection risk index, we arranged all 7 variables in increasing or decreasing order in such a way that the greater the value of the indicator, the greater the vulnerability to infection. So I want to give you an example of how we did this, and I'll use the indicator public transit users. So we looked at the 2016 Canadian census, and we found that the percentage of the population in each dissemination area, which is a unit used by the census that is close to a neighborhood in size, a couple blocks usually in an urban area. And we want to find out the number or the percentage of the population in each dissemination area whose main form of commuting is public transit. So we rank these percentages from highest to lowest so that the dissemination areas with higher rates of the population who are public transit commuters would be assigned a greater infection risk. And these values were then given a percentile rank across dissemination areas to achieve a relative value of infection risk for each dissemination area based on public transit use. And as a reminder, our indicators are based off a business as usual approach. So even though it has been found that public transportation is relatively safe with precautions in place like mask wearing and physical distancing, our models assume a status quo or constant ridership in normal pre-pandemic behaviors. Next slide. So the same method was used for the other 6 indicators, and an average was taken across all 7 indicators to calculate the overall infection risk for each dissemination area, resulting in this model that we have on the screen here. And as you can see, we have zoomed in on our map to Vancouver, and the lighter colors indicate lower personal infection risk, and the darker colors indicate higher infection risk. And it is important to note that because we used a percentile ranking system, these colors do not represent absolute values, but rather relative values in relation to other dissemination areas within the province. Next slide. So the same method was used for the other 6 indicators. Oh, sorry. The second model we developed was a relative exposure risk index to model the place-based risks we determined were most pressing. And the list was narrowed down to 12 indicators, which include things like density of bars and restaurants, percentage of farmland, percentage of presence of major mines, and density of long-term care beds, among others listed here. Next slide. To construct the relative exposure risk index, the same process was carried out, calculating a standardized value for all 12 indicators across each dissemination area. So as you can see here, these are the maps for the first 6 indicators, with pale blue indicating relatively low exposure risk and darker blue indicating higher exposure risk. Next slide. And then these are the maps for the other 6 indicators in our model. Again, pale blue is relatively low risk and dark blue is high risk. Next slide. Like we did for the infection risk model, we calculated the average value of all 12 indicators to calculate the overall exposure or place-based risks for each dissemination area to create this map of BC. Next slide. Finally, we added these 2 models together to produce a map of overall vulnerability for dissemination areas across the province. Once again, the values represented here are relative to each other and not absolute values. So light purple areas have a relatively lower vulnerability risk than dark purple areas. And I'll pass it back over to Valorie to talk about the qualitative methods of our study.
Thanks, Leah. So the aspects of our project that Leah has just taken us through brought us to the point where we were able to create maps along the lines of what you're seeing here on the screen. And if you have gone to the link to look at the interactive maps, you can see that the screenshot is certainly kind of less interactive and tells you a bit less information, but we were able to get to the point in the project where we were able to produce maps, wanted to have conversations with end users in order to get feedback on uptake, utilization, as well as any feedback that they might be able to provide us as well on the model itself. So are there variables that we've incorporated that they think are not relevant? Is there anything that we've done in this project that they think isn't consistent with the kinds of information that should be shared or incorporated into a model such as what we've done? We looked for, oh, sorry, Leah, you did one more map in there, but I'll just pass by that one. So we conducted a number of interviews with key informant end users who had positions where they were involved in making decisions with regard to COVID-19 pandemic management, people who work in public health positions, medical health officers, people along those lines. And we asked for feedback about our models. And these are the 4 main takeaways that we ultimately got from our interviews. The first is that the interviews really underscored the need to have an interactive map website. So that's what was shared in the chat screen or in the chat bar. And that is ultimately the format that we decided to share our models within, as opposed to stationary maps. The second point that participants really shared with us is that we need to give the appropriate kind of guidance to people so that they know what they're looking at, not just what they're seeing, but how to interpret what they're seeing with these maps. And so if you've already looked at the website, you can see many of those points of guidance actually incorporated in the text at the top. Also, talking with end users really shaped our thinking about what we were trying to show and why we were trying to show it, which sounds kind of funny, but even, for example, how we were going to title the maps, our use of the phrase vulnerability, thinking about risk, contracting COVID, these are all concepts that have a great deal of importance in terms of how we use language and what it is that we're talking about. And then finally, the interviews pushed us to really refine our variables. So there was a variable that we removed following the interviews because, as many of the people that we spoke with pointed out, it was no longer reflective of where the state of the evidence was. And also how we talked about some of the variables and the descriptions that we incorporated into the public facing aspects of this work really came through following our conversations with interview participants. In terms of the kind of guidance that they were suggesting that we provide people with so that it is possible to sort of interpret these maps properly, one of the things that we realized was really important to share is that all models have limitations. And I'm sure many people who are in this presentation today are very aware of that. But in terms of, members of the public who haven't had the kinds of scientific training that some people in this presentation may have had, it can be hard to know that models actually are putting together a hypothetical version of what the future or the past can hold, and it may not actually be fully accurate. And so we wanted to really, really emphasize that our models are intended to be used with other sources of information. They're not intended to be a singular source of information. The second aspect that we really felt was important to share is that the variables that we ultimately incorporated are those that we have information publicly available for, and that also have information available at the dissemination area. And so that was another important factor that was important to share, because there were lots of other variables that kind of come out, especially in popular dialogue, that have a great deal of importance in people's understanding of risk in relation to COVID-19, but many of them don't really have a very clear data link. And so those are things that we couldn't include. Also, we wanted to make it very clear that our model should not be used to attribute blame for transmission to specific people or particular places in specific neighborhoods. And this was very, very important, something that we wanted to make clear from the outset. And then also, as Leah said, our models make a business as usual approach to the variables. And so we don't actually factor in pandemic measures. And this has been a really important and interesting conversation to have with people. So often, and in fact, in other seminar presentations I've given about this work, people have asked, well, are we updating the models based on COVID rates? What kind of updates have we done? Our models actually don't factor in real cases of COVID-19, and they don't factor in the public health measures. And I think when you hear that, you might sort of step back and say, well, why are they important? But capturing the business as usual approach is incredibly important, because if we're seeing places and neighborhoods come up in our maps as being, high risk, but in real life, we don't see that actually coming through, then what we're actually starting to see are places where public health measures have probably had a good amount of success. And that's why it's important to actually look at this business as usual type of perspective. So again, we're not factoring in, as Leah mentioned, in relation to public transit, the fact that, if you are using PPE, for example, then it is quite likely that you're able to safely engage in public transit. We're not factoring in closures of businesses, for example. So that is something that is really important. And this is one of the kinds of decisions that we needed to make as a team, because from the outset, we were charting new territory with what we were doing. And we kind of had to figure out as we were going what we were doing and why we were doing it. And so this was a very important point for us to have a very clear rationale on as a team. So then in the end, if you have clicked on the web link that was shared in the chat, you will see something along these lines where you can see the factors or variables that we have incorporated. These are just kind of screenshots of what you're seeing. So there's nothing new here if you have looked at the online link, but I'm just showing you the variables that we ultimately included in the model. And you can click on the variables to look for a description of each. So we've got the different layers in the model that we have incorporated, and then bring them together into the sort of overall vulnerability. And we released this model. It's now like emblazoned into my memory. It went out on December 24th. Of 2020. And so effectively, I'd say for about 3 weeks, I was doing a very, very significant number of media interviews, podcasts, things along those lines. There was a lot of uptake. In fact, we were on we were the start of the 6 o'clock news on December 24th, on the day that we actually shared these maps. And I wanted to point that out, not to sort of point out the fact that there was news coverage from this, but to point out that in this project, we really took a public science kind of approach. We felt like it really wasn't justified for us as a team of scientists to wait to go through the process of publishing this in a journal and then sharing more widely. This is very timely work. And so we felt that we needed to take a very sort of open science approach to sharing it. So in fact, we shared this through issuing a press release through SFU that resulted in, as I mentioned, very significant uptake, where we not only had news uptake, but we had outreach from a number of end user groups that were interested in finding more information out about how we undertook this work, but also wanted to have meetings with us to help us understand how they could refine this type of method in order to use it in the context in which they were working. So for example, public health authorities across the country, Leah and I took a number of meetings with them, meetings with members of different offices offices in the British Columbia government. And so that was very, very interesting to kind of see how people in end user contexts were interested in applying the work that we had undertaken. The other thing about the release of this project via press release and getting the level of media attention is that, I mean, this is, jokingly, but kind of realistically, a visual representation of what my email inbox looked like over the end of December through January at the very latest in 2021. We had a number of people reach out asking questions, but one of the things that I felt was most engaging actually were people, members of the public, who were commenting or reaching out directly to ask a question and provide input or ask for an interpretation on something. And so it was very interesting to not only engage with end users as the kind of groups that I just mentioned, but also to talk to people who were looking at these maps and trying to make sense of them. Funnily enough, I'd say the most common question that I received, which will be interesting for people who are very familiar with the Vancouver area, is why is Stanley Park's dissemination area shown as high risk in a number of the maps? And the point that I made is that, I think many of us forget that there are business opportunities or businesses operating within the park, as well as residential complexes at the border of the park that are captured in that dissemination area. And so it was very, very interesting to actually see the consistency with which people were asking that question. But following the work that we did on this model, if you recall from earlier in the presentation, I mentioned that we had a number of objectives. And one of the other objectives is that we wanted to consider what the secondary health impacts of the pandemic might look like. So thinking kind of off in the future, once we're through dealing with, hospital capacity and outbreaks, what kinds of health impacts should we expect to see here in British Columbia, and particularly in neighborhoods? And, are we able to model some of those health impacts so that we can consider where we actually need to put resourcing and infrastructure in place now in order to potentially offset those risks being realized. And so this was the second model that we produced from our project. So in this case, as you can see here, the title was Mapping the COVID pandemic secondary health impacts. And I think Leah has included in the chat the link if you'd like to pull that one up and take yourself through the interactive map. We're not going to walk you through the process because it's quite consistent with the process that we used for the first model. And we want to make sure that we're, offering lots of space for questions, as that's more important. One thing I will mention in terms of undertaking our work on this model is that we felt that the information that we got from the qualitative component in creating the first model had a number of insights that were relevant to our work on this one. And so we didn't conduct additional interviews in developing this particular model. Once again, we released this model publicly. So we took that open science type of approach. We released it via press release from SFU. And again, we were getting uptake in media as well as other questions coming from members of the public. And I thought it was really interesting because unlike the first model, where much of the media coverage and interest that was coming as outreach was really focused on that model itself as a standalone, when we released this model, we noticed that a number of media reports in particular were combining this information with other sources of information in order to help to project. So you can see, for example, this headline in the middle of the news article, why BC's summer renewal won't look the same for everyone. And in this article embedded within it is discussion of our model, but also there are other information sources coming out that were shared in order to have this journalist paint the picture of what was going to be anticipated for last summer in British Columbia. So I thought that was quite interesting and really fell along the lines of the goals that we had as a team, which is that we don't want people to look at our models as standalone. We want them to incorporate them with other sources of information. And with that said, as I mentioned a moment ago, we want to make sure that we have a lot of opportunity available for questions, technical questions about the GIS, about how we did what we did, as well as other kinds of applied questions. So you have the ability on your computer to look through the interactive maps, to take a look at what it is that we've done and maybe think if you have questions, or perhaps you have questions generated already from this presentation. So with that, I'd like to thank everybody who's chosen to be part of this presentation and watch us today. You can follow me on Twitter, where I post any updates coming out of this project. We also have our pandemicgeographies.ca website, or you can reach out to me at my email address if you have any other questions that have emerged. And with that, I think we're going to open it up to questions, but I'll put it back to our collaborating center host.